My name is Robert Zeiser. I'm the Director of Tumor Immunology at Freiburg University Medical Center. And I will talk today about the REACH3 study that was presented at ASH in 2020. The background is that chronic graft-versus-host disease is a life-threatening complication after allogeneic hematologic stem cell transplantation that occurs in 30 to 70% of the patients that undergo allogeneic stem cell transplantation, and it is a leading cause of non-relapse mortality and morbidity. The standard first-line treatment for this disease are corticosteroids. However, half of the patients become steroid refractory and dependent. Therefore, new agents and therapeutic interventions are urgently needed for these patients. Today I will discuss the question if ruxolitinib can be considered as a new standard of care in these patients. To do that, I will introduce the REACH3 trial to you, providing evidence for using ruxolitinib. So the REACH3 trial is a phase 3 trial that demonstrated that ruxolitinib significantly improved outcome across a range of efficacy measures in patients with steroid refractory or steroid-dependent chronic graft-versus-host disease compared to best available therapy. In REACH3, patients treated with ruxolitinib achieved significantly greater overall response rate compared to BAT, with 49 versus 25% at week 24, which was the primary endpoint of this study. Also in key secondary endpoints, ruxolitinib showed superiority compared to BAT. First of all, failure-free survival, which is defined as a time to the earliest recurrence of the underlying disease or start of new systemic treatment for chronic GvHD or death, was significantly higher in patients receiving ruxolitinib compared to those patients receiving best available therapy. Another important aspect are the symptoms that those patients with chronic graft-versus-host disease experience, and those are quantified with a modified Lee symptom score. So patients treated with ruxolitinib had a greater improvement in patient-reported symptoms compared to those patients that received best available therapy. Additionally, this trial assessed the best overall response rate, defined as any response up to week 24. And that was also higher in the ruxolitinib group compared to the BAT group, with 76% in the Rux arm compared to 60% in the BAT arm. For those patients that experience chronic GvHD, it is important to also consider the side effects of the drugs that we are administering. And in this study, no new safety signals were observed when comparing the adverse events that were recorded in the ruxolitinib group compared to the BAT arm. The most common adverse events in the ruxolitinib arm compared to the BAT arm were anemia, hypertension, and pyrexia. So based on these findings, we have a new important therapeutic intervention for patients that have become refractory or dependent on corticosteroids for chronic graft-versus-host disease treatment. Those data support the use of ruxolitinib as a potential new standard of care. However, it is important also to experience a drug in the real world, and daily use basically. And that in addition to the approval by the authorities, namely the FDA and the EMA, will then define what is a new standard of care for patients with chronic graft-versus-host disease that have failed corticosteroid treatment. With that, I'm at the end, and I thank you for your attention.